It's a very interesting story about how this got approved. It actually tells quite a bit about how the regulatory process has changed over time. But there was a tremendous amount of pressure in the 1980s and early 1990s to really get cardiovascular risk reducing agents out to market because there was such a tremendous cardiovascular risk. And there wasn't much we were doing about it because this was often the pre-statin era. And there were studies like the Helsinki Heart Study in 1987 that did potentially suggest some benefit for fibrates like gemfibrozil in reducing cardiovascular events. But keep in mind that wasn't on the background of the statin and many of the newer agents that we have today. And so what happened is they ended up using a lot of surrogate endpoints, and they thought it was almost an oversimplified understanding of lipid biology. Just like you get the LDL down, you reduce cardiovascular events. They sort of concluded that if you get the triglycerides down and raise the HDL, you're going to reduce cardiovascular events. And we know that fenofibrate does reduce triglycerides and can modestly raise HDL as well. But turned out the story was not quite that simple because later studies showed that even if you get the triglycerides down and even if you slightly raise the HDL, that doesn't necessarily translate into cardiovascular risk reduction. So it was a combination of really the regulatory pressure that there was to try to get drugs on the market that reduce cardiovascular events, the misconception of using surrogate endpoints and sort of oversimplifying the biology, combined with the fact that there tends to be a lot of heterogeneity in terms of who responds to triglyceride lowering. And it's the, metabolic syndrome type of patient that's most likely to respond, and it's not a one size fits all when it comes to those types of patients. I think it's really important and it demonstrates another principle in medicine that I think is critical, which is that medicine changes over time. And what we were doing many years ago, for example, giving everybody a primary prevention aspirin, may not be necessarily what the new evidence continues to support, especially in a background of changing risk factor profiles and a background of changing additional pharmacotherapies and additional risk reducing agents. It really does emphasize the point that you don't want to continue that what's called clinical inertia. You just keep doing what you've been doing. You actually want to be active and thoughtful every time you see a patient and ask yourself, do they still need this medication? I don't just continue it just because it has been continued for a long time. And I don't just continue it because it treats the number. I really want to try to treat the risk. And that's what we know with fibrates. They treat the number, but they don't actually treat the risk, which is where that disconnect really is. I think the most important thing is to really clarify the new evidence without creating patient alarm and really without eroding patient trust. Because oftentimes patients are scratching their head and saying, well, you told me to take this for the last 20 years now. What's changed? And that's where it's really important to talk about some of the modern trials, such as the prominent trial, for example, that have really put the nail in the coffin on the fact that fibrates and fenofibrates specifically are not cardiovascular risk reducing agents. Now, they're still indicated in patients who may have triglycerides over 500, but the point of it there is to reduce the risk of pancreatitis, which is a complication of hypertriglyceridemia. It's not to reduce cardiovascular risk. So I think clarifying the evidence to a patient in patient-friendly terms so that they really do understand, but that we've learned new things, that they're new trials, and then on background of therapies that are proven to reduce risk, like statins and such, they don't provide additional incremental benefit to treat the patient's risk. I think that's one piece of it. I think another piece of it is really empowering the patient so that they're not left sort of with the rug pulled out from under them, but talking to them about what does work for reducing their cardiovascular risk. Certainly, I mentioned statins, but patients that have cardiovascular kidney metabolic syndrome or diabetes, we have agents like SGLT2 inhibitors, GLP-1 receptor agonists, and now we have an armamentarium of additional lipid-lowering agents such as PCSK9 monoclonal antibodies as well, with an oral option coming. So I think focusing on what works, clarifying why this something that they've been taking forever, we're now changing our minds on, and then really still continuing to enforce to them that they need to continue to be compliant with preventive therapies. Because sometimes if you put a little bit of doubt in a patient's head about one preventive medication, they may say, okay, I'm done. I'm going to get rid of the statin. I'm going to get rid of, my other risk reducing medications, my blood pressure medications and what have you. I think in the current climate, it's so hard to be a clinician or a physician right now because patients are coming in with a background perception of mistrust. And then if you bring to them, hey, this whatever we've been doing for the last 25 years is now different, it really does reemphasize that. So I think the biggest risk, as I mentioned, is really eroding that trust further and having patients attribute blame. Whether it's blame to the medical system, blame to the physicians, blame to the drug companies, or blame to the FDA, really exacerbating that problem. And what that can also do is lead to the phenomena of misinformation, which is really an explosive phenomena. So you could have a patient, for example, who's been on a fibrate for risk reduction since the 1990s. And now we know it's no longer necessary for risk reduction. So their doctor talks to them about how it's not necessary for risk reduction. And they go online and say something like fibrates don't work to reduce to help your heart or something generic like that, which could then get translated to a person that takes fibrates for triglycerides greater than 500, thinking that they should stop it. So I think there's sometimes that oversimplification in addition to that eroding of the trust and potentially of the blame. And you could also, like I said before, scare the patient enough that they throw the baby out with the bathwater and they stop everything abruptly, which can lead to rebound problems as well. So I think really setting the stage, contextualizing it for them, assessing their individual risk and deciding, what makes sense for them in terms of risk reducing therapies, and then making a plan that's personalized to the patient for how you can optimize. So what I like to tell my patients is, every time I see you, I'm going to apply the new evidence and the new science, and we're going to continue to make the drugs that we're giving you work best for you for where you are today, because you're a different person today than you were 20 years ago, and the medicines are different today than they were 20 years ago. And so that really helps the patients to understand that the expectation is that it's a dynamic process, that it's not something that's fixed. They're not going to stay on a medicine and then never end up discontinuing it or changing it. So, when I'm thinking of stopping fenofibrates, the first thing I do is assess their risk. And I say, okay, is this somebody whose triglycerides are high on fenofibrates, such that if I were to stop it abruptly, they would potentially go above 500 and could be at risk for pancreatitis? Or is it somebody whose triglycerides are really well controlled on the fenofibrate? And that's a phenotype of an individual where I may be able to stop it more abruptly. In general, my philosophy, because patients are more comfortable with a slow wean and approach like that, is to take some time getting rid of it so I can see how their body responds, and I can also help to assess, how their potential dietary changes could prevent them from having extremely high triglycerides that put them at risk. So the first thing I do when I'm thinking about stopping a triglyceride lowering agent like a fenofibrate is to assess whether there's any cardiovascular benefit to this particular patient. Are they the type of person whose trigs are over 500? And if so, I probably should continue a combination approach, statin plus fenofibrate. Or is it someone who was put on it because we thought it was reducing their risk and it isn't? So once I've decided then to stop it, then I usually wean it off, and then I end up checking their triglycerides. And the nice thing about triglycerides is that they respond pretty quickly. So you can check them as early as 2 to 4 weeks after any medication changes or dose adjustments. If they're just taking a single dose of a fenofibrate, I usually just stop it and then see where they're at relatively quickly so that I'm not leaving them at a high level for too long, and then counsel them on diet. And then I think about what's raising the triglycerides. So this is a really important point, which is that we want to go upstream of the triglycerides. The triglycerides are almost a manifestation of some other problem, whether it's obesity, metabolic syndrome, or poorly controlled diabetes. These are all things that can lead to high triglycerides. And now in the era of having GLP-1 receptor agonists, SGLT2s, as well as other cardiovascular risk reducing medications in that phenotype of population, that's the cardiovascular kidney metabolic syndrome, patients with diabetes, obesity, sleep apnea, HFpEF, AFib, I'm going upstream of what's causing those triglycerides to be elevated rather than just putting a band-aid on the problem by giving them a triglyceride lowering agent that doesn't reduce their cardiovascular risk. So it's really sort of a dance. You talk to the patient about coming off of it. You set the expectation that the triglycerides are going to go up, because sometimes patients get alarmed when they see that number suddenly go up. And then at the same time, you're adding on another agent, whether it's a GLP-1 receptor agonist or SGLT2, to treat their diabetes, treat their obesity, treat the cause of the elevated triglycerides, all while you're on the statin in the background. Then you let the dust settle and see where they ended up and what you need to do essentially from there. So, I talked about going upstream and certainly treating the obesity and the diabetes and all the other factors, including inflammation, that can raise the triglycerides. But really, there are other agents that have shown cardiovascular risk reduction benefit in patient populations that have, secondary prevention with high triglycerides or diabetics with high triglycerides based on the Reduce It trial. And that's icosapentaethyl is that agent, which is a highly purified form of EPA, which is a type of fish oil. Now, we know that over-the-counter prescription fish oils don't work. In fact, I'm stopping them in my patients all the time. They can actually cause harm because they can increase risk of AFib and they can have an antiplatelet effect. So get rid of those if your patients are using those, and don't use the mixed DHA EPA preparations. But if you've done everything, you've gone upstream, you've treated the obesity, you've treated the diabetes, you've gotten rid of inflammation, you've treated the chronic kidney disease, and the triglycerides continue to be elevated, I think of that as a target sign on your patient. It's really a marker that they continue to be at risk for persistent cardiovascular events, and that's when you want to reach for a risk-reducing agent like icosapentaethyl. Yeah, this is a tough one because, we know that even though we know some facts, sometimes changing clinical behavior can require a village. It can require a concerted effort. So to me, I think the biggest gap is the education, followed by clinical burnout and really lack of systems, processes in place to help physicians make these changes. So I'll address both of those individually. So I think, obviously I talked about the fibrate trials that came out in 2005 and 2010 that did not show cardiovascular risk reduction. And yet we are here 15 years later still using fibrates potentially for cardiovascular risk reduction. So I think there's a bit of a disconnect between what primary care physicians and other physicians perceive, or what their kind of historical knowledge is compared to what it now happens in modern day. So I think bringing the knowledge to them using evidence-based summaries, using CMEs, using short little educational tidbits, like educational shorts, I like to call them, just like you see the shorts on YouTube and TikTok and Instagram and such, is really important way to bridge that gap. But I think it needs to happen on an ongoing basis because we know that the FDA made a label change to fenofibrate earlier this year, and it sort of fell through the cracks. It didn't get the kind of media attention that one might have normally expected. So really sending that information to the clinician at the bedside so that they can continue to understand that it's important. It's already made it into the guidelines, but sometimes guideline documents can be lengthy and difficult to digest as well. So really creating educational formats that people can use on the go, I think is really important. I think it is also really important to try to have systems in place, whether it's AI systems, whether it's electronic medical record systems, that can actually alarm physicians, trigger some kind of an alarm if a patient is on a fenofibrate that can be turned on in 2026 now that there's a label change, and say, does this patient still need a fenofibrate? With a little clinical blurb that says there's been a label change, these are not cardiovascular risk reducing medications, and please continue to assess the ongoing appropriateness of this. I know that sometimes when my system alarms me, it does help me take notice that maybe, I forgot to screen them for depression, or I forgot to think about some other risk reducing strategy. So I think using clever ways to really help the clinician to identify these patients rather than giving the clinician one more thing to do and putting another thing on their plate is more likely to be effective in the long term if we can automate much of this. And this could even come from the patient level. For example, if a patient goes to a pharmacy to fill a fibrate prescription, there could be an educational blurb that goes out to the patient that says, talk to your doctor about whether this is still necessary for you because there have been some significant changes to the label of this particular medication recently. I think it's really interesting to see how this came to market and how things have really evolved over time. And I do think that this demonstrates a deeper structural problem in how we think about approving agents. And I think the challenge here is, of course, that the FDA continues to evolve as well. The regulatory standards continue to evolve. So often do the thought experiment that if a fibrate had been, submitted for FDA approval today, in 2025 or coming up into 2026, would it still have been approved based on surrogate endpoints, and based on the really the lack of strong clinical evidence that led to fibrates approval? So that's my first question, and I think the answer is no. And I think the FDA has really made its standards more stringent over time, which has been a really positive development because we're now looking for actual clinical trial endpoints. We're looking for established efficacy. Of course, we're always looking for safety before you bring something to market. You're not just basing it off of surrogate endpoints. But I think what continues to be a problem in the FDA, which is really a structural problem that continues to persist over the last several years, is the inability to change things as the science changes. So, I mentioned multiple trials have shown no benefits of fibrates, and yet, the label change just happened in 2025, even though some of those trials had initially come out in 2005 and 2010. So, why does it take so long for something to be undone when it's not showing benefit? Now, of course, if there was a safety signal, I think they might have moved a little bit faster because I think safety always gets people's attention. But lack of efficacy to me is also a mistake. It's an egregious error to continue to give somebody something that doesn't improve events. And any drug can have side effects. Of course, drugs have cost associated with them. So, on a population level, we're doing a huge disservice by continuing to use something for the last, 10 to 15 years, despite solid clinical trial evidence that's randomized trials that don't show any benefit. So I do think that this teaches us a lot of lessons moving forward about surrogate endpoints, certainly about lipid biology, certainly about oversimplification or, extrapolating data about LDL to triglycerides or HDL raising, but also about how we ought to start to evolve regulatory approvals when the science changes and what really needs to be done to withdraw it. Now, one thing the FDA didn't do this year, which I kind of wish they had, was to send a letter to all clinicians indicating that they had changed the label. They declined to do that despite the citizens petition, filed asking them to do that. So to me, that's going to continue to create a little bit of a barrier in terms of education and dissemination of education, getting that information out there and getting clinicians to really adapt or change what they're doing.